Dr. Little. You've heard from me before if you've watched these videos. I'm the medical director at SKY Rehabilitation Hospital, and we're going to talk a little bit about strokes. Right now is stroke month, and happy stroke month to you. I'm wearing my coronavirus haircut today, as a lot of us are, so that'll be my excuse for that. It's taken me back several years. Anyway, stroke month is a very important time for us because our stroke population is a completely separate certification, and that's very important. We deal with the physical things that everybody sees in stroke, but from our perspective, the more complex part of stroke and the most difficult part of stroke for a family member is the mind and the thinking and the things we can't see. Everybody can help somebody that has a weak arm or a weak leg. They can help them walk or help them eat or help them dress. But the thing we try to add here is that very complicated part that happens inside the brain in terms of thinking. And I thought I'd take the opportunity to say today to comment on that, but also to introduce how we deal with that differently than other people do. When I first arrived, we didn't have a very key component to that. We did not have something called a neuropsychologist. We all know what a psychologist is. This is not just a psychologist. This is a psychologist that has that very strict scientific piece that has to do with measuring what's wrong with the brain and then making recommendations as to how to fix it. I practice with and without neuropsychology, not very long without because I insist on it, and it's not the same. It's very difficult for me to do a physical exam, and I do a very careful exam to know what's going on in the head, and it's almost impossible for me to know where specific deficits are. So our neuropsychologist here at the hospital does the part that we can't see. He takes tests of the patient, and the patients cooperate to varying degrees, you might guess that. He may be able to do a very simple test, which is very basic, but gives us some simple information. Most of the time, we're able to do a battery of tests that have different components in it. And those components are what we call dominant side and not dominant side. And on the dominant side is the things we all see every day. Can they speak? Can they do a math problem? Can they remember things? On the other side are the things we don't see and which are by far the most dangerous. So typically, if you see somebody with right-sided weakness, if they start getting up in the top of the brain where we think, you notice they can't talk, or they can't do a math problem, or they can't remember things. The other side of the brain, typically with the left hand, on the left weak side, they cannot tell where they are in space. They shouldn't be using power tools, but you'll never know that by looking at them. So by the time we do a discharge here, we will have measured both sides of the brain, and Dr. Perri will be giving us information on what we do, particularly on that other side, to help avoid danger for one thing, but also how to help fix it. So I'm going to drop it off here, and I'm going to let Dr. Perri talk about what a neuropsychologist does and why it's very important to your stroke family member.
Hello again. I'm Dr. Perri. I am also sporting my COVID haircut here, trying to simplify. As Dr. Little just mentioned, I am a clinical neuropsychologist here at SKY Rehab. My work, as he was detailing, really has to do with the cognitive aspects of any type of acquired brain injury. And of course, we know that a stroke is an acquired brain injury first and foremost. So my role with patients is working alongside them to determine the impact of the stroke on their thinking. And literally, a stroke could impact all levels of thinking in a patient, and of course it depends on the neuroanatomical location of the stroke itself. If it's right side, left side, so dominant hemisphere, non-dominant hemisphere. What we do with folks that are here in the hospital is typically a series of tests and interviews to determine what symptoms have come about as a result of the stroke, what symptoms maybe were there prior to. And of course, our focus is going to be on new symptoms, new onset, helping the patient to understand the changes that have been brought about in their thinking as a result of the stroke, and then ultimately what tools can be used to overcome them. Of course, that goes without saying that falls back on SKY is a rehab hospital, so our work goes hand in hand with the skilled therapies that are administered to the patients, and we can help to determine what those symptoms are and how to go about combating them. What we know about long-term recovery from stroke is that awareness of the symptoms that are present is a key ingredient towards 6 months down the road, 1 year down the road, having a full recovery from that stroke onset. It may sound intimidating as far as neuropsychological testing. I can assure you it is a painless procedure for the patient. Maybe not always for me, but it is painless. Much of it is paper and pencil testing, and the key thing is that normative data is used as well for comparison purposes. We do not expect a 60-year-old to outperform somebody that is in their 20s or 30s in terms of memory functioning. So we always want to compare apples to apples along those lines. Usually I will see a patient several times while they're in the hospital in order to determine progression with regard to those symptoms, and then we can make follow-up recommendations on an outpatient basis as well.